Good evening. Welcome to the ONS webinar on osteoporosis. Thanks for coming. Hopefully this is informative. It's at least a distraction from the current election reporting. And as you know, I cannot see you, just so you know that. And I will be taking questions in our question and answer period at the end. So I have a PowerPoint presentation, and it's just about after 5. We now have 62 people on this Zoom call. So let's get started. So osteoporosis. Hold on for a second. Let me just see if we can get things to work the way they're supposed to. So let's talk about some statistics about osteoporosis. Here are some facts. These are constantly changing. This is from the National Health Service, but 10 million Americans are affected by osteoporosis. 33.6 million in one of the later studies shows that they have low hip bone density, and 50% of white women will occur in osteoporotic fracture, as well as 20% of men through their life. Osteoporotic fractures result in many admissions. One study showed 432,000 admissions, with 2.5 million office visits and 180,000 nursing home admissions annually, as you see. Just as a sort of number for costs, this is a huge bill. In 2005, there $17 billion was spent on osteoporotic fractures, and this is slated to triple by 2040. So hold on, sorry. So you need to know a little bit about bone structure, and we'll go over some part of bone metabolism to understand osteoporosis better. Here is sort of a line drawing of a typical bone. And what you see in a bone is that there is an outer part of the bone called the cortex that's sort of the strong part of the bone. Then there's the inner honeycomb portion of the bone that leads to some added strength to the bone. So bones are essentially tubes with a matrix inside, and we'll keep going. Why I put this slide in here to sort of highlight why I'm speaking about osteoporosis. I've been in orthopedics for 35 years, in Greenwich, Connecticut for a lot of those years, and we see lots of osteoporotic fractures. The most common fractures are spine, hip, wrist, and pelvis. As I got further along, I became more interested in prevention of osteoporotic fractures. I still fix a lot of these things, but I think it's incumbent upon us and the orthopedic community to discuss osteoporosis in a prevention, as a prevention maneuver. What is osteoporosis? Well, there is a World Health Organization definition of osteoporosis, but osteoporosis is a loss of bone mineral density, or a BMD. It's often reported as. The World Health Organization shows this graph, and this is a bell curve of bone densities, where the 0 point is here in the middle, and that is the normal, and anything on this side of the normal is an elevated bone density, and on the other side, this side of bone density is a loss of bone density. When you get to 2.5 standard deviations, that's what these bars represent. When you get to 2.5, that's considered osteoporosis. Before you get to 2.5, you go through an area here that's called osteopenia. That's at or about 1 standard deviation below the norm. So people often ask me, how did you come up with the norm? Well, the World Health Organization actually looked at 6,000 people that are healthy people in the state of Texas. And they used that to determine what was normal bone density. These were healthy young people, and then everything was compared to that. And so as you see here, as I say, the definition here of osteoporosis is below 2.5 standard deviations below the norm. This is on a DEXA scan, and we'll talk a little bit more about DEXA scanning, but DEXA scanning is the gold standard of the evaluation of bone density. It is an X-ray. It's on a special machine. It's not a standard X-ray. It's on a special machine that cannot be changed in terms of the contrast and the picture. Interestingly enough, it does help to go for comparison bone densities to the same machine when you have a follow-up bone density, theoretically every 2 years or so, if we're sticking to some of the recommendations. So DEXA scanning is the gold standard. There have been other evaluations of X-ray, including heel X-rays and things like that, but that's not those are not accepted evaluations. The DEXA scan is the only true accepted evaluation of bone density. So what does osteoporosis look like? So here you see a comparison slide of a microscopic cross-section of a bone, and this is normal bone. You see that honeycomb-shaped matrix in the middle of the bone. We're not showing you the outer part of the bone, but the inner part. This is normal bone. They're robust. They look like, bridges. You go over here and you see very thin spicules of bone with even hairline cracks through this. And this is what the ultrastructural microscopic look of an osteoporotic bone is. So that gives you a little bit of a feel for what osteoporosis looks like. Now, there are a lot of different ways to evaluate osteoporosis, and one of them is a FRAX score. And this was something also designed by the World Health Organization that didn't take into account your general health generally, or a lot of testing, but sort of was an attempt to sort of it was a tool and a questionnaire that gave people some estimate of whether you were a person that was going to have an osteoporotic fracture within 10 years. And those questions involved race, age, gender, BMI, family history, smoking history, whether you had a previous osteoporotic fracture, whether you had rheumatoid arthritis, diabetes, whether you were menopausal or hypogonadism refers to your hormone levels. If you were on the wane in your hormone levels, if you'd ever taken steroids for more than 3 months, and it does include a bone mineral density, it's BMD, that's supposed to be, in this picture. And it was an attempt to characterize your risk for fractures. It's more of a statistical analysis, but people talk about your FRAX score, whether you're going to be a person that could theoretically fracture something within 10 years. In order to understand osteoporosis, you have to understand a couple things about bone. Bones are not static structures. People make the assumption that, your bone is kind of your building blocks and it doesn't change. Well, that's not true. There is constant bone turnover at all ages. As a matter of fact, under the age of 10 to 12, you make a new skeleton every 8 to 12 months. Your maximum bone density is achieved between the age of 18 and 25. So that's when your skeleton is the strongest. Some people say that osteoporosis is a pediatric illness, because if you never achieve that high bone density from the beginning, then you're whittling away from a lower number through your lifetime. So people have stressed that for whatever reason, children don't reach their maximum bone density, either through poor diets or other things. that they may be more prone to osteoporosis later in life. So there have been some people that have focused that we are not doing enough in the pediatric population to build bone density. I have to put this slide in because I must say that I get this question all the time. And osteoporosis, although it sounds like osteoarthritis, are two very different things. And here we have a side-to-side comparison of what osteoporosis is. And as we talked about, it's about a loss of bone density. Osteoporosis is painless. When somebody comes in and tells me they wonder if they have osteoporosis because something hurts, that's not from osteoporosis. So until you either fracture something or something else happens, osteoporosis does not hurt. That's why it goes unchecked for a long time. It is age-related. So osteoporosis occurs as we get older. It's much more common in women. There are, just to back up for a second, there are osteoporotic conditions that occur in younger people. There's one that's an overexercise phenomenon. There's eating disorders that cause osteoporosis. That's not really what we're talking about today. We're talking about the more run-of-the-mill osteoporosis here. But we'll talk about a little bit about some of those other features as well. Again, more common in women. White women, more common in Black women. This is the one time where weight is actually somewhat protective. People that are very thin, slight frames, those people are much more prone to osteoporosis. And again, although weight is not good for other systems, it's a little better for your bones. And this affects bones, not joints. So when people say it hurts when I move my hands because they're stiff, that's not osteoporosis. On the flip side, osteoarthritis is a degenerative disease of joints. Joints hurt, they're swollen. It too is often age-related, although there are conditions that cause joint problems that are not, people can have this at a relatively young age. And in this situation, men and women get osteoarthritis at a pretty much a similar rate. And increased weight in osteoarthritis is a major cause of arthritis. So there it's not protective. So osteoarthritis is not good to be overweight. So now we'll go to bone metabolism. And just as an aside, you will be able to ask questions to me through a question and answer type in, and I will be answering those toward the end of. And so if you come up with questions, jot them down or remember them and type them in to the question and answer phase, and I will be addressing those questions at the end of this talk. So bone metabolism, which is how bones are made and broken down, you have to know that osteoblasts are cells that make bone. We have a lot of those. They come from sort of general cells that get differentiated into osteoblasts. And then there are osteoclasts, and I have a pictorial that goes over this again, but just to give you some nomenclature here. Osteoclasts are cells that come from the same cell line, but they differentiate into cells that break down bone. The mix of these two things causes bone remodeling. So your skeleton is always being broken down and remade. Some of the things that affect remodeling and breakdown and formation are vitamin D. We're going to discuss these things. Calcium, a hormone called parathyroid hormone, and then estrogen, testosterone, which are sex hormones that are responsible when they start to wane and later in life in either menopause in women and just senility as time goes on in men. Those things affect that balance, the equilibrium, and we'll see that. So here is a kind of cute little cartoon of bone breakdown and bone formation. And in this scenario of bone remodeling, what you see here are that there are cells that come from the blood that then become made into bone these are called osteoclasts. And so these are bone breakdown cells. And you can see what they're doing to the bone. They're eating it away here. So they eat away at the bone. And then what happens in a balance situation is that after they've eaten up the bone, new cells are then layered on the bone. These are called, oh, hold on, sorry. Let's go back. These are called osteoblasts, and these are making new bone as depicted here. And then the bone gets sort of cemented in place, and that's mature bone. This is what normal bone looks like. Again, we saw that picture before. Now, when things are out of whack here, for whatever reason, whether it be postmenopausal or for whatever reason, and there are lots of reasons, and we'll talk about those, this bone breakdown gets accentuated. We don't make so much bone, and then we have poor bone at that point at the end that is not so robust. Sorry, I keep hitting that by mistake. And that's where the picture here looks like that. And that's osteoporotic bone leading to fractures. And so this is sort of the whole thing you need to remember about bone creation and bone breakdown and when it's out of balance. And that's important. The balance is what we deal with in terms of trying to reverse this. But you're going to get you'll get more of that as we go on. So how do we know you have osteoporosis, and who is the best person to deal with this? Well, if you come see me as an orthopedist, you've missed the boat, because usually the only time I see people with osteoporosis is when they've broken something. So the ship sailed at that point. And so if you have osteoporosis, we'll talk about what you can do about it. But we'd like to deal with it before you break something. So who deals with this? Well, because this is more skewed to women, a lot of obstetricians and gynecologists, which women see annually, have sort of adopted the management of osteoporosis. And some of them do a really good job of it, and some just sort of think it's an add-on to what they do, and they don't really pay a lot of attention to it. A lot of people were put on Fosamax, which is a biphosphonate. We're going to talk about that for long periods of time. It's just sort of a thing, and not really looked into the underlying causes. And only some obstetricians and gynecologists really pay attention to the osteoporosis. They're busy doing other things. Internists have also been sort of adopted some of the management of this, but they too tend to be pretty busy with this, with general medical practice and too many other things going on. And I have found that they are also not really interested in managing or evaluating the sort of nitty-gritty of osteoporosis. Endocrinologists, on the other hand, are my go-to people for this. They understand hormones, they understand metabolism, and I generally refer people to endocrinologists once we have a question of osteoporosis for whatever reason, whether it be from a fracture or whether, and that's where I generally see them. Or if there's any question, we'll talk about what kinds of things spur people to go on to evaluate osteoporosis. So here are the risk factors in osteoporosis. So menopause is the #1 thing that we see in this country and around the world, actually. So people, as with the population's aging, we go through menopause, and then estrogens start to go down, and we get out of balance in terms of making and breaking down bone. Age is definitely a factor, even in men. Over the age of 70, and some people say 75, testosterone levels start to go down and people get out of balance again. So females are much more likely to have osteoporosis. Light-skinned people and slight stature are real issues. Asians actually have a reasonable amount of osteoporosis, which kind of is counter to what I'm saying. But I mean, when I see somebody who walks in and they weigh 100 pounds and they're 5'7", I'm worried as time goes on that they're going to have osteoporosis. A family history is a strong predictor of problems. A previous osteoporotic fracture is a very big indicator. And to be honest, if you've had an osteoporotic fracture, as the ones we talked about, wrist, hip fracture, spinal compression fracture, then a pelvic fracture, you have osteoporosis by definition until we prove otherwise. Kidney disease is a huge osteoporosis maker because your kidneys hold on to calcium, and if you don't have calcium, you wind up osteoporotic. GI conditions, so gastroenterology conditions such as malabsorption situations from surgical procedures, lactose intolerance, that's a lifelong thing that kids have, and that's where sometimes we get into trouble with children. Celiac disease is another one that's we're recognizing more, so those people have osteoporosis. Steroid use is a very big contributor to osteoporosis. So people that are on steroids for whatever reason, because they have autoimmune issues generally, or asthma and things like that, those people have a high incidence of osteoporosis. Smoking is not a good thing for a lot of reasons, but osteoporosis as well. Alcohol consumption is another one. Excessive alcohol consumption. I'm not saying you can't go home and have a cocktail or a glass of wine, but if you're drinking regularly excessive amounts, that leads to osteoporosis. People that are infirmed, people that for whatever reason can't get up and walk, those people are more likely to have osteoporosis. And cancer treatment and cancers themselves, and there are certain cancers that are particularly bad for this, do lead to osteoporosis. The treatment is part of the problem. Some of these chemotherapy drugs are very toxic to bone and can lead to problems. So this is a sort of, there are more things in this, but these are the main risks to osteoporosis. Some medications actually promote osteoporosis, and one of the ones that came up that's very widely used is heartburn medication for reflux, for GERD, Prilosec, Prevacid, Nexium, and on and on. There's all kinds of new ones out. And why is that? Because you need an acid milieu in your stomach in order to absorb calcium. And if you have suppressed that, then that can cause poor calcium absorption and therefore lead to more osteoporosis. Diuretics, a lot of people are on diuretics, especially as we get older. Kidneys don't function as well. Your heart doesn't function as well. You tend to retain water. And things like Lasix and hydrochlorothiazide, just as sort of are examples of diuretics, tend to wash out your calcium content and cause problems. As we said, steroids are very potent osteoporosis makers. Chemotherapy, anti-hormonal drugs. So some of the anti-hormonal drugs, such as in prostate cancer, things like Lupron and raloxifene in breast cancer and things like that, tamoxifen can also promote osteoporosis. Some of the birth control pills that suppress estrogens can also do that. And people always ask me about thyroid replacement. Thyroid replacement, as long as it's monitored carefully, is not a risk for osteoporosis. However, if it's not monitored carefully and somebody's put you on Synthroid or levothyroxine and you've not been monitored to see that the levels are adequate, then you can be overdosing on Synthroid, and that causes osteoporosis, or overdosing on thyroid replacement. So what diagnostic tests would you normally go through if you were concerned about osteoporosis? Well, as we said, the gold standard in screening for osteoporosis is the DEXA scan. And that's this X-ray of the wrist, the hip, and the spine. And it's reported out as this minus 2.5 standard deviations below the norm, resulting in osteoporosis. And that's a computer-generated report that's done by radiology groups. Routine lab work is something that we usually do. So we do a CBC, electrolytes, liver and kidney panels, because general medical conditions can cause problems. A 24-hour urine test is also helpful because we're trying to see if your kidneys are filtering out calcium or if you're excreting it. If you're excreting calcium and your 24-hour urine shows that you have a high calcium level, your kidneys are part of your osteoporotic function. As we said, thyroid functions tests, there are some small glands in the neck called parathyroid that secrete parathyroid hormone. And if that level is high, that tends to cause your body to start to chew up your bones, and that can be overactive. And people with osteoporosis that for no good reason can have hyperparathyroidism from an overgrowth of these small glands in the neck and cause severe osteoporosis. Vitamin D levels are important, and we're going to talk about specifically of vitamin D. And there's these other two blood studies called CTX and NTX that are measures of bone resorption, and that's something can be measured in the blood. It tells us if you're in a high bone resorption condition initially, and then we institute treatment, we often monitor these to see that things are getting better, that you're not eating up your bones, because these are blood tests that go up when you're chewing up your bones, such as heading toward osteoporosis. So those are that's a reasonable battery of tests in the diagnosis of osteoporosis. So what kind of treatment do we have? That's really what people want to know. And let's start talking about calcium. So calcium is always in the forefront of discussion of osteoporosis and management of osteoporosis. What's your calcium requirement? Well, it changes through your life, but as we get older, it's generally between 1,200 and 1,500 milligrams a day of elemental calcium. So in nursing women, it's in the 1,200 range. In children, it's in the 900 range. But anybody over the age of 50 probably needs something in the 1,200 to 1,500 milligram range. How do you get it? Well, you get it from a couple different sources, and it's calcium carbonate is the most common way to get it as a supplement. Tums is calcium carbonate, Oscal is calcium carbonate. The problem with these medications is they need an acid environment to be absorbed. And so if you have reflux and you're on, let's say, Prilosec or omeprazole, you don't absorb things very well. So what do you do about that? Well, calcium citrate, although it doesn't have as much calcium in it, doesn't need that acid to be absorbed. And so although it's less, as you see in the next comparison, calcium carbonate is 40% calcium and calcium citrate is 21, calcium gluconate and calcium lactate, not very commonly taken, but calcium citrate's only 21, so it's half as much of calcium as calcium carbonate. So all calcium is best given around mealtime, especially calcium carbonate. So it's better to take it with a meal than to take it on an empty stomach. To get enough calcium through your diet is not easy. As you see here, just a smattering of things that have calcium in them. 8 ounces of milk gives you 300 milligrams of calcium. Well, you know, you'd have to drink a lot of milk to do that. Yogurt's a little better. Cheddar cheese, you'd have to eat a huge block of cheddar cheese to be even close. Ice cream is always a good one, but it doesn't have as much calcium as we'd like. Fortified orange juice is actually pretty good for that. And then you look into other things that have calcium. Soy products, such as tofu and some soy milks and things like that have pretty good calcium. Nuts, sardines has pretty good calcium, not the boneless sardines, but the bone-in sardines. Broccoli has pretty good calcium, cabbage and okra. Spinach doesn't have good calcium. Although there's calcium in spinach, it's locked up in a compound called calcium oxalate that can't really be absorbed very well. So that's not a good thing to eat for calcium. It may help with other things, but it's not good for calcium. Caffeine is a pretty good calcium leacher. So actually, caffeine, if you're a big coffee drinker, if you drink excessive coffee, that can reduce your calcium intake. Beans are also, because they have calcium oxalate, are not a good source of calcium and may actually block some calcium intake. Very salty foods also can wash out calcium and block calcium resorption in the kidney. So salty things are not such a good idea either. Magnesium is kind of poorly talked about. It's there is a daily magnesium requirement, 300 to 500 milligrams. Some foods have calcium, and you can look those up. As I say, it's not focused on very much, but supplements like magnesium glycinate or gluconate are readily absorbed, and you need a baseline level of magnesium. Magnesium is necessary in a lot of different reactions in the body, but it's also for bone formation, it's important. So vitamin D, a very hot topic nowadays. How do you know if you're vitamin D deficient? We in the Northeast are often vitamin D deficient, particularly during the winter, because vitamin D is created in the sun, in the skin, when the sun shines on your skin. The problem also is that there's been, the dermatologists have browbeat us into not being out in the sun because of the incidence of skin cancer. So people are in the sun less nowadays. But vitamin D is very important. And I feel that a vitamin D serum level, which is a blood test, is really the only good way to know where you stand with vitamin D, the normal range being 30 to 50 nanograms per ml, which is a number, but that's the only real way to know, are you vitamin D deficient or not. Vitamin D increases your calcium absorption of things you eat. It also helps in making bones. What kinds of things are high in vitamin D in terms of natural vitamin D? Fish, egg yolks, seafood. As we said, ultraviolet light is critical, but you may have an argument with the dermatology people. Supplements are the standard way of receiving vitamin D. There are milk is often fortified with vitamin D, but most people take supplements. There's a lot of debate about how much you should take a day. 2,000 a day is kind of middle of the road number for your vitamin D requirement, but you can overdo vitamin D. If you are vitamin D deficient, your doctor will prescribe for you a sort of 3-month period to build back your vitamin D, and it sometimes can involve substantial doses of vitamin D, even up to 50,000 units a week, to really rebuild your level. But the only way to know you've rebuilt it is to get a follow-up serum level. So vitamin D is critical. We need to be taking that probably. So what other things now let's talk about some of the real pharmacologic treatments of osteoporosis. What do you do if you have, somebody's made the diagnosis of osteoporosis through a bone density? Well, so one of the groups of medications that we prescribe is called bisphosphonate. If you remember back at my little cartoon, there were cells called osteoclasts that broke down bone, and that balance gets out of whack as you go on in life and go through menopause, or for whatever reason, all those things we talked about. So what do bisphosphonates do? Well, they block osteoclast formation. So here we are now with reducing the number of osteoclasts, and these are the names of drugs that were prescribed that are in the bisphosphonate family. And, oops, sorry, I'll go back. So Actonel is very common. Fosamax has actually been taken off the market because of some trade issues. Boniva, reclassed. Reclassed is interesting because this is a once-a-year injection. Boniva is once-a-month medication. So these medications reduce the osteoclast formation, and it theoretically brings your bone equilibrium back in balance, and may even shift you to building bone. Now, they're not great at that because usually at this time of your life, postmenopausal women, as an example, you're not building a lot of bone, but you're still breaking it down at a fairly high level. So bisphosphonates can increase your bone density somewhat, but more so, they stop it from getting worse. The problem with these medications are a few things. Number one, if you again go back to thinking about that little cartoon, remodeling, to make strong bones, you need to break bone down and then remake it on a regular basis. What happens in this situation is you're not breaking it down and you have a low level of making bone, and you can get what was called atypical fractures here. Your bones can get brittle because we're not going through that remodeling cycle on a regular basis. And people that have been on these things for long periods of times sometimes develop spontaneous fractures because of the medication, because your bones got brittle. They look pretty good on a bone density, but they're not strong. It's essentially like a piece of chalk. And so chalk is brittle and it can break. And people have had fractures, particularly of the femur, the thigh bone, of just walking down the street. And so there have been recommendations that you not be on these medications for more than 5 years at a time without getting off them for short periods of time. Now, that's very controversial now. There have been some other studies that show if you stop these things, that your risk of fracture goes up. So these were the go-to medications for a long time, and really the only first medications that came were for the treatment of osteoporosis. They're kind of changed. That's changing around a little bit, and they're falling out of favor a little bit. There is another condition that can occur, this jaw osteonecrosis. It can result in necrosis of your jawbone and loss of teeth. It can be a big mess. Just to say that these should not be taken if you're having implant surgery, because that requires bone to grow into your implants. And so you wouldn't want to be on these when you go for dental implants. So these are medications that a lot of people took for a very long time. I think a lot of people are still on them, but there's definitely a red black box warning on these medicines that they shouldn't be taken for long periods, and there may be better ways of dealing with it. We'll talk about some of those. Here's one that's relatively new, Prolia. It's an every 6-month injection. If there was a subtle thing there in my little cartoon called rankle that turns cells into osteoclasts, and this blocks that rankle step that causes osteoclasts to form. It's similar to biphosphonates. But it's an injection once every 6 months. It does have some of the side effects though, and some of the same concerns. This is a newer medication, but it's still the same mechanism is involved, and that's reducing osteoclast formation. So it can still have jaw osteonecrosis as well as atypical fractures. It's been around only for probably 5 years or a bit more. So we don't have a long track record like we do with the other bisphosphonates. So it's yet to be seen how long people should be doing this on a regular basis. But this is a very popular medication nowadays. What about hormone replacement? Because we talked about the fact that as we go through menopause, estrogens start to decline because that's the definition of menopause. There was at one point along the way, people were taking estrogen replacements after to prevent menopause, or at least moderate it as people went through early menopause. It fell out of favor because of some studies that came out that showed that estrogen replacement can predispose you to strokes and heart attacks. It also can increase the risk of breast, ovarian, and endometrial cancer, as well as increased blood clots, but not patches or gels. So estrogen kind of fell out of favor. The classic one was Premarin that everybody was on, and the studies pretty much put the companies out of business making Premarin. But actually, in revisiting some of those studies that came out, the incidence of increased strokes and heart attacks is actually lower than originally found in those studies. And estrogen replacement early on after or going either perimenopausal or menopausal women are now starting to reconsider this. And a lot of doctors are reconsidering because if you can maintain estrogen levels at some higher level, you prevent a lot of osteoporosis. And some of the increase in osteoporosis we've been seeing over the last 10 years has to do with the discontinuation of estrogen replacement. There is a medicine that also called Evista, which binds to estrogen sites that sort of mimics estrogen, but it's not estrogen. And some of it may reduce your risk of breast cancer. It still has a risk of blood clots, though. And it's used by some people. It's not as popular as some of the other osteoporotic treatments, but it is out there. So in case you hear about Evista or raloxifene as a treatment option, you'll know why. So parathyroid hormone, we talked a while back about the parathyroid gland in the neck causing a reduction and an increase of calcium and eating up of your bones. Well, if used correctly, actually, parathyroid hormone makes bone. And this is a medication. Forteo was the first one. There's a new one called Tymlos that came out. It was a daily injection for 2 years. It comes in an injector pen, and it's actually simple to do on your own. It's not painful. The needle is infinitesimal. And it was the first medication that came out for the treatment of osteoporosis and still around that actually builds bone. Everything else we talked about here either supports bone or stops the eating up of bone by osteoclasts. This actually increases bone formation. It doesn't have anything to do with osteoclasts. It has to do with osteoblasts, and it creates new bone. So this was a sort of really a miracle almost in the treatment of severe osteoporosis, that we could actually reverse osteoporosis. A lot of the other things we've talked about here kind of stabilize osteoporosis, don't really build it back, but parathyroid hormone can build bone. The problem was that in the original trials of this medication, used at very high rates in mice, they actually created some bone tumors. Osteosarcomas formed at 2,000 times the normal dose of the medication. So there was a warning on this medication that if used for more than 2 years, there was a possibility that you could create a very aggressive bone tumor called an osteosarcoma. In clinical studies, there have been virtually none that have been reported because the dose was so far over the norm that it whipped the bone so much that every now and then people got cancer from it. So it's unusual, and I don't think it's a worry, but it's why it's been limited to 2 years. There have been some recent studies that have been looking at going on for longer, and I think we may see that as time goes on. What about exercise? Well, I get a lot of people saying, well, I can't have osteoporosis. I exercise like a fiend. I'm always walking, I'm running, I'm jumping. There are a couple studies that showed that it's not doesn't insulate you from osteoporosis. There is a law in medicine called Wolff's Law that bone responds to stress by getting stronger. So people took that to say, well, let's stress bone by doing weight-bearing exercise such as walking and things like that. It takes a lot of exercise to increase your bone density. It's a bit unreliable. It's just a singular modality for managing osteoporosis. Interestingly enough, just as an aside, a lot of astronauts have osteoporosis because they're in a weightless condition. And when they come back to Earth, they found that people have osteoporosis because there's no weight on their bones. So that's the Wolff's Law idea. But unfortunately, the flip side doesn't work as well. But you need to be exercising, because a lot of what happens in osteoporosis is people fall. And so fall prevention is critical. And I'll have a little slide here in a minute about fall prevention. But balance is important. Yoga and Tai Chi are, been touted as being useful for osteoporosis. It's more about the balance than it is about osteoporosis. But weight-bearing exercise is really what we're looking for. People ask me about things like swimming and even sometimes biking, not as good as walking, running, jumping rope. Now, obviously you have to be the right person to be doing some of those things, because there are other conditions that may obviate you from doing that. As I said, fall prevention is a part and parcel to a discussion of osteoporosis. And I actually lecture on fall prevention in addition to this, and that's a whole separate topic that's literally an hour's worth of a lecture. I'm just looking to see if I'm getting overtime. Here I am. So anyhow, these are some things I want to have time for questions here. But reviewing your medications, looking around the house, a vision evaluation, the right shoes, be careful about pets. I can't tell you how many people get tripped up by their dogs and break things. And going out in bad weather is my pet peeve. When people break their hip and I asked what they were doing, they were getting the newspaper on a slippery day. Really bad idea. All right, I think I made it to the end. So I'm gonna see if I can look up questions and answers here. Okay, I have questions. So let me read them and we'll go on from there. So I have one question here. The drug therapies have significant side effects that seem more serious than a fracture. Well, I don't know about that. Are the drug risks of jaw or femur damage worth the benefit? Will vitamin mineral productions like bone up work? Okay, so I must tell you, hip fractures are really the big bugaboo of osteoporotic fractures. And hip fractures are serious problems. I mean, people never often regain their independence after hip fractures, especially as we get older with multiple medical problems. So I think that an osteoporotic fracture can be pretty serious. Unfortunately, vitamins and mineral products don't rebuild osteoporosis. They may help you stabilize what you have, but it won't reverse osteoporosis. The only way to reverse it are some of these other medications that we talked about. So hopefully that helps. I have another question here. I'm a 69-year-old man with osteopenia, and I'd like to avoid osteoporosis. I take 2 Caltrate a day and exercise a lot, but since I'm only scanned once every 2 years, how do I know my Caltrate is enough and my exercise is enough? My fear is that by the time we see a pattern, I assume it's too late. The answer to that is, the only way to monitor this, as we said, is to do all those things you're doing. Caltrate, the amount of Caltrate you're taking may be less than I'd like. As we talked about, the other things that the other workups may be useful if you're concerned to see an endocrinologist and get the rest of the workup, because sometimes there's more to it, and sometimes I think we don't want it to be too late. So I think it's this is enough for now, but I think understanding a bit more would be helpful. The next question: after being on Fosamax for 11 years, I suffered an atypical fracture of the femur. Following femur surgery, I was placed on Forteo for 2 years. What would be the next patient? What would be the next medication after that? Well, that's a really good question. There are a lot of people that are moving on to Forteo after that. So there isn't a good answer for that, unfortunately. And unfortunately, some of the studies of Forteo showed bone increased in bone density, but it waned relatively quickly after taking you off Forteo. So people want to seal the bone, and that's where sometimes people have moved on to Forteo or even back to the bisphosphonates. But unfortunately, being on bisphosphonates for 11 years uninterrupted may be part of the problem. I do think you need a holiday from these medications. Let's see. Next question. How do you evaluate and choose medication for osteoporosis treatment? 4 doctors have prescribed 4 different medications. Yes, there definitely are different philosophies of what to do. They all have a role to play. There isn't one best medication here, unfortunately. There's no good answer to that question. There is, I just as an aside, if you want more information, go look at the website, the National Osteoporosis Foundation, or NOF. You'll get a lot of answers there, but you're not going to get anyone that says this is the only way to do it. There just isn't one way to do it, and that's why even good doctors may come up with a different plan than another doctor. Next question is, I'm a 51-year-old woman, premenopausal, was diagnosed with low bone density at the age of 46. I was using steroids for asthma. Okay. Not sure that that was the cause. My numbers were in line with osteoporosis, but because of my age, I was told it was not technically osteoporosis. There is no age cutoff for osteoporosis, first of all. I see an endocrinologist and have bone density tests every couple of years. Are you seeing more younger women with low bone density? Yes, I mean, I think there's been an explosion of antacid type medicines like Prilosec. And so those people are more prone to it. Asthma, steroids, inhaled steroids do cause potentially some osteoporosis, but it's a low number and not a big contributor. I would say, but I disagree with this sentence that at 46 you can't have osteoporosis. I have 20-year-olds who are anorexic that have osteoporosis, so it's not an age thing. And I think that an endocrinologist needs to keep testing and treat at some point, because at 51, I'm concerned that I'm going to meet you in the emergency room with a broken hip at the age of 65, and we don't want to do that. So that's a problem. Let me go on because there are a lot of questions here. At what age should a female patient begin to get tested for bone density and osteoporosis? All of those factors, early menopause, small stature, family history, are all reasons to be tested sooner than later. I would say that your first bone density on average is sometime after the age between 50 and 55. After that, it's earlier if you have more of the risk factors. So again, in the interest of trying to get to most of these questions, let me move on. Are collagen supplements good? The answer is no. It's as simple as that. There is no collagen supplement that is for the management of osteoporosis. How much of your body needs to be exposed to get vitamin D, and how long do you have to be in the sun? Does walking in the sun count? Any exposure to the sun counts. But I will tell you, dermatologists are going to yell at you for being in the sun, and have exposed skin. We have had an explosion of skin cancer. Some people feel that the ozone layers have been thinned out and we are seeing more UV light. I'd rather see you getting it through supplementation than sitting out and getting cooked in the sun. It's just not worth it. Too much melanoma, too many basal cells, and actinic keratosis. As being a fair-skinned fisherman, I can tell you I spend a lot of time in the dermatologist's office. Is an elliptical as good as a treadmill for preventing osteoporosis? No, it's not weight-bearing. It's not impact. If you had to pick something, go walking. Elliptical isn't as good. Is walking with a weighted vest useful? Yes, anything you do to increase your weight-bearing is useful, so it helps. Thank you so much. Well, thank you for doing this. I thought you said parathyroid hormone causes osteoporosis. Abnormal parathyroid hormone causes osteoporosis. That's true. But parathyroid hormone at these levels builds bone. So it's a little counterintuitive, but that's the case. So hyperparathyroidism causes a decrease in bone, but the right level causes bone increase. If you do not want to take drugs to increase bone building and have osteoporosis, what then? Exercise, take, eat those foods that are natural, get adequate vitamin D, calcium, magnesium, and don't get older. That's an hard one. Should I stay on Avista indefinitely for my osteopenia? Well, I mean, I think it does help as long as it's not causing issues here. I would discuss that. There are definitely other options. I would discuss that with the doctor that prescribed it. There is an incidence of increased blood clotting, and you'd have to be careful with that. Will we get a copy of presented slides? This webinar will be available, if the complete webinar will be available through ONS, so you can get it there. What about the treatment by infusion once a year? That's reclassed, zolidinic acid. I must tell you, I'm not a huge fan of it because if you have a reaction to it, we can't do anything about it. And if you break something during that year, there have been some studies that show that healing may not be as robust. So I'm not a huge fan of that. I'd rather see you doing something that was discontinued. That zolidinic acid actually persists longer than a year and does shut down your osteoclast activity. So when bone remodeling occurs, it may not work as well. So fracture healing is maybe retarded. So I don't love it, to be honest. It is convenient because you only have to worry about it once a year. I'm on Fosamax for about 1.5 years so far. Will I be able to get refills due to the trade issues? There's other medications like it, like Actonel. The other question was, I know I will need a medication vacation at some point fairly soon. What can I take after Fosamax? There are other things to stick with bone density. It's a hard question. There aren't good answers for what to do after you've taken the course of this. There have been some studies now that show that these medication holidays are not such a good idea. It's still unclear. Do these companies, OsteoStrong, that claim to help osteoporosis with a few minutes in the machine work? It's a good question. There's not a lot of studies about that except from the OsteoStrong people. The idea is that these machines create stress in your bones. As I said before, there was a lot of enthusiasm toward weight-bearing exercise fixing osteoporosis. It may stabilize it. It may not really return you back from osteoporosis. For postmenopausal women who cannot take hormones, what are other options I might have? Well, all of those things that we talked about instead of hormones, I mean, weight-bearing exercise, calcium, vitamin D, and all that, as well as, watching it carefully is an option. If you can't take it because of previous breast cancer, as we said, Avista or raloxifene is actually used to prevent breast cancer. Back to the question, do collagen supplements help? The answer is no. There's no study that shows they help. I'm a 73-year-old male, underweight, have trouble putting weight on, low BMI, have been a vegetarian for 40 years. Daily swimming is my exercise. Should I see an endocrinologist? You should probably at least have a bone density to start with. Dietary issues in people that are not getting enough food in their diet and are vegetarians need careful monitoring. Let's put it that way. So I would get a bone density, and you surely could see an endocrinologist. There's nothing wrong with doing that. At best, at worst, they say everything's fine. At best, they identify that you have osteoporosis and may prevent you from having a fracture. How bad is Advair? These are the inhaled steroids. They've been said not to really contribute substantially to osteoporosis, but that's a little up in the air. I mean, look, if you need them for asthma, you need them. So anyhow, I think the answer is if you need it, take it, but it may be worth monitoring it. I took Prolia for 3 years. The pain was unbearable. What does the medicine cause so much pain, and when is it supposed to help you? If it's causing that kind of joint pain, you would stop it. I mean, you shouldn't be on Prolia if it's causing that kind of pain. You need to look for a different medication. There are side effects to these medications, including bone, muscle, and joint problems. I wouldn't keep taking it. If it's doing that, it can be causing other issues. Is supplemental calcium linked to heart issues? The answer is not straightforward. It used to be no. There have been some studies that show that high calcium levels can cause arterial calcification, and high vitamin D levels can as well. So the answer is take it within the normal range, but not excessive calcium. It probably is not a big issue, but the reason that all came up is that there are CAT scans as screening studies for cardiac issues. I'm going to try moving quickly here because I know we're coming to the end of this. Do you feel that a bone density scan is helpful? Yes, I've had them every 2 years, and it always says osteopenia, not osteoporosis. Well, that's a good thing. 18 months ago, I tripped on a floor and broke my femur in 2 pieces. Well, that can happen whether you have osteopenia or not. I'm back on Boniva. Medicare doesn't pay enough to cover Timlos. I take calcium. You can do what you have to do. You know, there are definitely people that fall and break their femur. You hit if you fall on a concrete floor. I mean, so I think I would stick with what you got and just keep getting bone densities and see where you go, and see an endocrinologist if there's any question. Is estrogen being prescribed again? Yes, people are, internists are prescribing more estrogen than they were because of the studies that show that may have been overstated in terms of the risk of strokes and heart attacks, particularly perimenopausal women. If you take it later in life, after being postmenopausal for long periods, it may not be that helpful. I've been recommended to go on Fosamax. I have osteoporosis linked, likely exacerbated by synthroid medication that has changed in dose. I now need less over the past years. Is it worth taking? If you have dental issues, if you have gum disease and dental problems, there could be other reasons not to take this. So there are other options. If you're concerned, I would see an endocrinologist and talk about that. After my 2 years on Forteo, what might be the next step? A lot of people are prescribing Prolia every 6 months after Fosamax. It's still unclear what to do after Forteo. As I said, there may be Forteo more than 2 years in the coming future. We'll have to see. I'm a 58-year-old woman with osteoporosis, not on medication. Do you see patients to evaluate therapies? Do I personally see them? I don't see osteoporosis patients. I lecture on it. I can advise you, but again, I generally advise people to see an endocrinologist. They're better at this, and to be honest, I'm most of the time dealing with orthopedic and musculoskeletal problems. I don't specifically treat osteoporosis myself. I refer them, and I would see a number of endocrinologists, and if you, I'm happy to provide you with some names if you want, or you can speak to your internist. I have osteopenia and my internist wants me to be on Prolia, and my OBGYN insists not. I am 70 and otherwise active. Go see an endocrinologist. I mean, I'm not trying to be flip. I'm just trying to speed up so I can see most of these. A rheumatologist informed me that the RA has chewed away at my wrists. I have bone density scans, but not of my wrists, my hip, spine, osteopenia. I'm 73, took Fosamax, then Actonel. I was young then. Does RA look like osteoporosis? RA can predispose you to osteoporosis. It can cause bone density issues. It's one of the causes of a spurious bone density. So I would say, again, if there's any question, see an endocrinologist. That would be helpful. I'm 65 and postmenopausal. Okay, most people at 65, to be honest, are postmenopausal. All of the things we talked about would be helpful, including a bone density. Do you suggest following up 5 years on Actonel with Prolia, or take a break? I generally would say take a break. These medicines work similarly. I'm under 60 years old and have been on Actonel for 1 year, and so hopefully have a long haul ahead. Any new drugs on the horizon? only Forteo is the newest thing around in Prolia. Thank you for the information. Again, I'm not trying to be quick here. I'm just trying to get through most of these. If you have a family history of osteoporosis, do you recommend taking medications for prevention purposes? No, not for prevention purposes, just calcium, vitamin D, exercise, those things. Can you mention a few endocrinologists that you've worked with? Dr. Renee Leva, L-L-E-V-A, Dr. Judy Goldberg-Berman. Those are the two people in Greenwich that I generally refer to. I like them very much. They're very interested in osteoporosis.